result from acute or chronic inflammation triggered by a persistent viral or bacterial infection. Common diseases of the tonsils and adenoids are acute tonsillitis or adenoiditis, recurrent or chronic adenoiditis or tonsillitis, obstructive hyperplasia. This is actually due to non-infectious cause, and also malignancy. Tonsillitis most often occur in children. However, the condition rarely occurs in children younger than 2 years. Tonsillitis caused by Streptococcus precei typically occurs in children between ages 5 and 15, while viral tonsillitis is commoner in younger children. Now, peritonsillar abscess, which is actually a lethal complication of the adenotonsillar diseases, occurs in teens or young adults, but may present earlier. Pharyngitis accompanied by upper respiratory tract infection between 2.5% and 10.9% of children may be defined as carriers. In one study, the mean prevalence of carrier status of school children for group A Streptococcus was 15.9%. I tried to get literature that has maybe epidemiology and prevalence for West Africa or Nigeria. I couldn't find. Okay, let's just move to embryology. So basically, the tonsils and the adenoids develop in the 8th week of life. Usually, most of the organs develop between the first 8 weeks. So the first 8 weeks is actually essential for an embryonic development. Just a quick recap from our basic embryology. We know that from the 5th week, the pharyngeal arch begins to form. And then basically the tonsils and the adenoids develop from the pharyngeal arch. Especially the first and second pouch of the pharyngeal apparatus. But then embryologically, the tonsils and the adenoids develop from the epithelium of the primitive oronasal cavity, mesenchymal stroma, and lymphoid cells. And the tonsils increase rapidly in size between the 1st and 3rd year of life, with peak in the 3rd and 7th year. They involute slowly before early puberty and finally disappear before the age of 20. Tonsils and adenoids belong to what we call lymphoepithelial tissue, and they consist of the lingual tonsil, that's this one, and then the pharyngeal tonsil, which is also referred to as the adenoids, and then the palatine or facial tonsil, and also the posterior and lateral pharyngeal wall parts. Now, these 4 components that I just mentioned form what we call the Waldear's ring. So as I said, the tonsils are lymphoid tissue and they are covered by respiratory epithelium, which is the pseudostratified ciliated columnar epithelium. Now, the blood supply to the tonsil is via ascending and descending palatine arteries and also the tonsillar artery. These 2 are branches of the facial artery. However, 1% is from the aberrant internal carotid artery, just deep to the superior constrictor muscle. Now, the venous drainage also follows the same pattern, whereas the adenoid is supplied basically by the ascending pharyngeal and sphenopalatine arteries. So the physiology now, the tonsils are situated at the opening of the pharynx. At the opening of the pharynx, situated at the opening of the pharynx to the external environment. The tonsils and the adenoids are in position to provide primary defense against foreign matter. Now, basically what they do is that they produce lymphocytes and are active in synthesis of immunoglobulins. Now, the lymphoid tissue of the Waldear ring is most immunologically active between ages 4 and 10, and then it decreases after puberty. Now, there's no major immunological deficiency demonstrated after removal of either tonsils or adenoid. So that means when there's indication for tonsillectomy or adenodectomy, once the advantages supersedes the clinical presentation, once you do like a surgery, there's actually no immunological deficiency. The child can still strive well. Now, the pathology now. So basically, I think I will dwell more here because this is the crux of the whole adenotonsillar diseases we'll be talking about this evening. So the first part is the acute infection. So now, viral or bacterial infection and immunological factors can lead to tonsillitis and its complication. And then factors such as overcrowding and malnutrition also promotes the manifestation of this disease. Most episodes of acute pharyngeal tonsillitis are caused by virus. Now, the common virus that has been implicated is the herpes simplex virus. Other viruses are the Epstein-Barr virus, which also is linked to the infectious mononucleosis, and also the cytomegalovirus and the adenovirus, and also measles as well. There's a particular research that was done that showed that Epstein-Barr virus alone can give pharyngitis or tonsillitis that can produce exudates, which is similar to what we see in bacterial infection. Now, group A beta hemolytic streptococcus pyogenes is the most common cause of bacterial infection in the pharynx. Now, the strep pyogenes adheres to the adhesine receptors that are located on the tonsillar epithelium. The immunoglobulin coating of the pathogens may be important in the initial induction of bacterial tonsillitis. Now, other bacteria that are implicated in acute infection are Mycoplasma pneumonia, Corynebacterium diphtheria, Chlamydia pneumonia. But this one, they rarely cause acute pharyngitis anyways. And then Neisseria gonorrhea has been implicated also in sexually active persons. Recurrent tonsillitis. A polymicrobial flora consisting of both aerobic and anaerobic bacteria has been observed in core tonsillar cultures in cases of recurrent pharyngitis. So basically, for recurrent pharyngitis, the organisms that have been implicated are the Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza. For chronic infection, the tonsils and adenoids can be chronically infected by multiple microbes, which include a high incidence of the beta-lactamase producing organism, such as the streptococci that we mentioned earlier. Also, Haemophilus influenza and anaerobic species of other bacteria, such as the Streptococcus, also predominates in chronic infection. So apart from infection, another disease that could affect the tonsils could be hypertrophy or hyperplasia. And in most cases, they actually manifest with airway obstruction. Now, we know that both the tonsils and adenoids are major, when they are enlarged, enlargement of tonsils and adenoids are major cause of upper airway obstruction in children. Now, airway obstruction in children is typically manifested in sleep disordered breathing, which include obstructive sleep apnea, obstructive sleep hypopnea, and upper airway resistance syndrome. Sleep disorder breathing secondary to adenotonsillar breathing is a cause of growth failure. That's the failure to thrive that we see in some children. So apart from tonsillar hypertrophy that would cause airway obstruction, another manifestation is tonsillar neoplasm. Rapid enlargement of one tonsil is highly suggestive of a tonsillar malignancy, typically lymphoma in children. So for the acute infection, recurrent infection, and chronic infection, usually the swelling is bilateral. But in situation where unilateral swelling is seen, then malignancy should be highly suspected. So the clinical features. For acute infection, now the symptoms include odynophagia, dry throat, malaise, fever, chills, dysphagia, referred otalgia, headache, muscle ache, and enlarged cervical lymph nodes. The signs you could pick on examination include dry tongue, erythematous, enlarged tonsils, tonsillar or pharyngeal exudates. This is very, very common with acute infection. Could see palatine petechiae and enlargement and tenderness of the jugulodigastric lymph nodes. Now, we have different types of acute tonsillitis, the acute cataralis, the acute follicular, and then the acute parenchymatous, and also the acute membranous. Now, the acute catarrhal superficialis, this is usually the common one we see, and is caused by virus mostly. And usually the tonsils are enlarged with or without the presence of, usually without the presence of exudates. It's just enlargement, an area of hyperemic region over the pharynx and then the tonsils. Then the acute follicular type of acute pharyngitis. Now, this is associated with some purulent discharge around the crypt. Sorry, this one now. So there's actually an enlargement, and then once you check around the crypts, around these crypts and this one, the fossas here, you could see some exudates. Now, the next one is the acute membranous. Now, the acute membranous is the typical presentation that is seen, especially in bacteria infection, where you see there's enlargement of both tonsils and you could see exudates. Where's my cursor? Okay, you could see exudates, and usually the enlargement can even overshadow the presence of the uvula or even displace it, as it's seen here. Okay. Yeah, so for chronic infection, children with chronic infection or cryptic tonsillitis often present with halitosis, chronic sore throats, foreign body sensation, or a history of expelling foul tasting and foul smelling cheesy lumps. When you examine such throats, what you usually see is that the tonsils are almost any size, and they often contain debris and also crypts too, just almost similar with the membranous presentation I showed us earlier. Now, basically, what causes chronic tonsillitis? It could be from complication of acute tonsillitis. So if you have an acute infection going on for a while that has not cleared, it can be complicated to give a chronic tonsillitis. Subclinical infection of the tonsils also, chronic sinusitis or dental sepsis can result to chronic tonsillitis. And then it mostly affects children and young adults. Now, types of chronic tonsillitis, there's chronic follicular tonsillitis, chronic parenchymatous tonsillitis. Now, this one, the tonsils are very much enlarged uniformly and may interfere with speech, swallowing, respiration, and long-standing case may develop into pulmonary hypertension because of the blockade of the nasopharynx. Then there's chronic fibroid tonsillitis. So the clinical features for chronic tonsillitis basically is recurrent attacks of sore throat, chronic irritation in the throat with cough, there's halitosis, that's bad breath, there's dysphagia, that's difficulty in swallowing, there's odynophagia, pain on swallowing, and thick speech. Now, the signs that can be elicited on the examination is that the tonsils will be enlarged depending on the type. There will be flushing of anterior pillar compared to the rest of the pharyngeal mucosa. And then there's also going to be enlargement of the jugulodigastric node. Usually it's going to be soft and non-tender. So that's that for the infectious cause of adenotonsillar disease. Now, airway obstruction. Now, airway obstruction can be due to hypertrophy of the tonsils. And usually you can diagnose it from the history and examination. Usually the patient would not present with fever as in acute or chronic tonsillitis. But then the most common symptoms the patient would present with would be symptoms that would suggest adenotonsillar hypertrophy. And the symptoms can be divided into daytime symptoms of airway obstruction and nighttime symptoms. The daytime symptoms include chronic mouth breathing, nasal obstruction, hyponasal speech, hyposmia, decreased appetite, poor school performance. Now, the night symptoms include loud snoring. So you hear patients complain that their children like snore loud, like a young child will be snoring heavily like an adult in the night. Could be choking, gasping. There could be frank apnea. There could be restless sleep, abnormal sleep position. There could be night terrors, diaphoresis, enuresis, and then sleep talking. Now, when you check on examination, the tonsils are usually enlarged, but in most cases, they might be unilateral. You could see some features of obstruction. The size of the adenoid tissue can be demonstrated on a lateral neck radiograph with a flexible endoscope. Other signs that can contribute to airway obstruction include the presence of craniofacial syndrome or hypotonia. So how do we manage adenotonsillar diseases? Now, the management is depending on the types I've discussed earlier. So first of all, you take history. History is very important. So depending on the history now, you'll be able to classify the disease as acute, as recurrent, or as chronic, or maybe as a hypertrophic disease, or maybe a malignancy. Now, the clinical features, I've mentioned some of them earlier, which is important for acute tonsillitis, pain, swelling, and all those pain on swallowing, and then sore throat, all can be seen in clinical features. And then the signs too. When the patient opened their, just what I discussed earlier, when you examine the throat, you would see the lymph nodes are enlarged, the tonsils are enlarged, sorry, and then there's going to be enlarged lymph nodes also. And then depending on the type, there could be exudates, or it just could be a hyperemic, like in the case of viral infection. Then examination is very important. Now, for examining any adenotonsillar disease or infection, first of all, you ask the patient to open his or her mouth. You do an oral inspection. You first of all tell the patient not to protrude the tongue, just to open, so that you do a buccal inspection. In most cases, you could see like the enlargement, or at least the hyperemic firing. Then you could look for a tongue depressor and depress to see as far back inside the throat. Ask the patient to lift their tongue a bit so that you inspect the buccal regions. You look for the salivary ducts. You look for oral hygiene, whether the patient has good oral hygiene. Look for exudates also, just like a general inspection of the mouth. And in some cases of hypertrophy, you could use like a nasopharyngeal flexible probe to look as far back into the nasopharynx. Now, the investigation that can be done depends on the presentation. So for acute infection, usually the diagnosis is clinical, but then you could do a full blood count. You could do an EUC to check if the electrolytes are elevated or not. And then most importantly, or what the gold standard is throat swab, especially in the case of bacteria, tonsillitis, or adenoiditis, where you take some of the swab from the exudate and culture it. In recent times, I think there's some other diagnostic tools that can be used, such as the rapid antigen dictation test. In that case, it helps to dictate, especially streptococcus, the group A streptococcus pyogenes organism. And usually, since it's a rapid test, the result will come out earlier than the normal throat swab we do. The advantage is that it has 95% specificity, though it's not a very sensitive test, but then it has been useful in management, especially in developed countries. Now, the treatment proper. Basically, you would advise for, depending on the presentation, if it is acute and the patient can go home, you encourage bed rest, liberal food intake, or proper hydration. You could give analgesics and antibiotics. But in cases of severe presentation, when the patient cannot swallow, and then there's obvious toxic symptoms, the patient is in crying spells and there's fever and all, you could admit the patient. Now, if you admit the patient, the hydration would be through intravenous route, and even the analgesic and the antibiotics you would give would be IV. Now, the most common antibiotics that is used is any penicillin group. So the common one we use, especially in Garki Hospital or Nigeria generally, is the amoxicillin clavulanic acid, which gives a very good result. So normally you should treat the infection between 7 to 10 days. In the case where the patient cannot tolerate orally or might not be compliant with oral medication, IM benzathine penicillin G can be used, but then the patient will have to be on admission. Then other antibiotics that have been found to be useful is clindamycin, cephalosporins, macrolides, example, erythromycin. Also, vancomycin and rifampin has also been used in recent like treatment, recent trials, like in some of the materials I saw, could use vancomycin and rifampin. But then basically the mainstay is penicillin. So admission, if unable to take orally, a tonsillite or debris may be expressed manually with either a cotton tip applicator or a water jet. Chronically infected tonsillar crypt can be cauterized using silver nitrate. Still, as part of the management, tonsillectomy and adenodectomy can be considered. So tonsillectomy alone is usually performed for recurrent or chronic pharyngeal tonsillitis. The indication for surgery remain uncertain. There are large variations in surgical rates among children across countries. Like this study I saw, like in Italy, the rate is up to like 144 per 10,000. In Netherlands is 115 per 10,000. In England is 65 per 10,000. In US is 50 per 10,000. I'm sure in Nigeria and other developing countries is going to be high. I didn't see any literature as regards that. And then the rate for tonsillectomy is higher in boys as compared to girls. So the indications for tonsillectomy, though these are not are non-evidence based, but then these are mostly what would point out to make a clinician to consider referring the patient for tonsillectomy or consider doing a tonsillectomy. Now, if there's 7 or more throat infections treated with antibiotic in the preceding year, is an indication. When there's 5 or more throat infections treated each year of preceding 2 years, so you have like in the past 2 years, the patient has treated for tonsillitis like 5 times, so like almost 10 times, or 3 or more throat infections treated with antibiotic each year of 3 preceding years. Now, the American Academy of Otolaryngology, Head and Neck Surgery offers guidelines of 3 or more infections of tonsils or adenoids per year, despite adequate medical therapy. The Scottish Intercollegiate Tonsillectomy Guide Network recommends 5 or more episodes per year of tonsillitis with disabling symptoms and lasting for longer than 1 year. So tonsillectomy has been shown to be effective in reducing the number of infections and the symptoms of chronic tonsillitis, such as halitosis, persistent or recurrent sore throat, and recurrent cervical adenitis. In resistant cases of cryptic tonsillitis, tonsillectomy may be curative. Tonsillectomy has not been shown to offer clinical benefits over conservative treatment in children with mild symptoms. So in children with mild symptoms, we don't have to insist that they have tonsillectomy done because the benefits doesn't really outweigh the patient's clinical state. But then, like I mentioned earlier, in case of recurrent infection, then that would be needful. Okay, still as okay. Indications for adenodectomy in case of obstruction. That's in case of chronic nasal obstruction or obligate mouth breathing, when there's sleep disordered breathing with failure to thrive, or copulmonary, when there's dysphagia, speech problems, severe oropharyngal or dental problems. Now you can do an adenodectomy. In case of infection such as recurrent or chronic adenoiditis, that's any infection occurring 3 or more episodes per year. In case of recurrent or chronic otitis media, this is also indicated. So adenodectomy alone may be indicated for the treatment of chronic nasal infection, that's chronic adenoiditis, chronic sinus infection that have failed medical management, and recurrent bouts of acute otitis media, including those in children with tympanosomy tubes who may suffer from recurrent otorrhea. Adenodectomy may be helpful in children with chronic or recurrent otitis media with effusion. Adenodectomy alone may be curative in the management of patients with nasal obstruction, chronic mouth breathing, and loud snoring suggesting sleep disordered breathing. Adenodectomy may be indicated for children in whom upper airway obstruction is suspecting causing like a craniofacial or an occlusive developmental abnormalities. So the criteria for both tonsillectomy and adenodectomy for recurrent infection are the same as those for tonsillectomy alone. The other major indication for both procedures together is in upper airway obstruction secondary to adenotonsillar hypertrophy that will result in disordered breathing, failure to thrive, craniofacial or occlusive developmental abnormalities, speech abnormalities, or rarely copulmonary. Now, high proportion of children with failure to thrive in the context of adenotonsillar hypertrophy resulting in sleep disorder experience significant growth acceleration after adenotonsillectomy. So what are the differentials of adenotonsillar diseases? Well, basically, they're actually spectrum of diseases anyways, from what I spoke to, from like the chronic, from the acute, chronic, the hypertrophic disease, I know. But then basically, especially the acute now, the other close differential that we could associate it with is infectious mononucleosis. And this is because of its link to Epstein-Barr virus. Now, malignancy, like lymphoma, leukemia, carcinoma, to our close differentials, diphtheria, scarlet fever because of the fever that comes with its presentation, and agranulocytosis. So the complication of adenotonsillar disease include peritonsillar abscess. This is common with acute infection. There's parapharyngeal abscess, retropharyngeal abscesses, intratonsillar abscesses. All these abscesses are related to acute or recurrent infection. There could be tonsillar cyst, tonsillolite, and there could be focus of infection, rheumatic fever or acute glomerulonephritis. That's because of its link with beta streptococcus pyogenes organism. So these are images of how some of the complications look like. So this shows peritonsillar abscess. See, this one. So this is pleomorphic adenoma. Okay. So other tonsillar pathologies now that is not covered under what I've discussed include fungal infections, include hyperkeratosis, fungal infection like mycosis leptotricha, and tonsillitis. So this candidiasis too is another fungal infection that could affect the tonsils and the adenoids. Retention cysts, this is another manifestation of adenotonsillar diseases. There could be supratonsillar clefts, as shown here. Okay, basically. So, what's the role of the family physician in management of adenotonsillar disease? There's a literature I saw. I think I included it in my reference. It was a research that was done in Ekiti as recent as 2017 about adenotonsillar hypertrophy. And then they got statistics that usually family physicians are 50% the primary contacts of the patient, and then I think 25% internal physicians, and then 25% ENT surgeons. So the family physician is usually the first person to have contact with the patient. So prompt diagnosis and treatment is very key. So being able to identify and know the kind of presentation that will be managed at home, or the kind that would be managed in the hospital under admission, and then also to refer when the need arises, especially when there is recurrent tonsillitis, or there's chronic tonsillitis. I think at that point the family physician can refer. And also when there's indication for tonsillectomy or adenodectomy or any other surgical procedure. But then most of the cases we see, especially in clinic here, are the acute pharyngitis, and we can manage them as outpatient basis. Okay, in conclusion, adenotonsillar diseases are common ENT disorder in our environment. All primary healthcare physicians, that is family physicians, pediatricians, and otorhinolaryngologists, should have a good knowledge of this ailment. This disease burden can be prevented or reduced. The incidence of associated complication can be abolished. Thank you. These are my references.
Thank you very much, Dr. Kopkuk Magzendi. Wonderful presentation, wonderful slides, very interactive with pictures and all that. So let's give her a round of. Thank you, thank you, thank you. Yeah. So okay, let's see from the questions on the chat window. Okay, so Dr. Ijabo asked you, what are kissing tonsils? What are kissing tonsils? Have you heard that before?
Kissing tonsils. Okay, yes. They are usually bilateral inflamed tonsils that actually overlap and meet at the midline. Yeah. And those ones actually are very severe, painful, and they come with obstructive symptoms.
Okay. All right. Thank you. So
it's almost like that has slide 27.
Slide 27, okay. They were meeting at the midline, yeah. So those are kissing tonsils. They are common with very recurrent tonsillitis. So, with the recurrence, the tonsils get enlarged, and they come to the midline and meet and cause some kind of obstruction.
And that takes us to grading of tonsils. Have you heard of the grading of tonsillar hypertrophy?
Oh, okay. Yes, but I had limited time to add some stuff on hypertrophy, so I couldn't really like pick up. But then I think I will check it up. I can't remember the grading, but I saw something like that.
Maybe you had limited time, Maxendi. Which limited time? Topic I'm giving you since early beginning of the month. It's a limited time. That is not acceptable. That's how it will be like. I just grabbed that yesterday and say prepare tonsillitis. Something for over 3 weeks. You're saying limited time.
It's quite quirky.
Anyway, next question.
I don't know if you can help me. The grading, I can't remember.
Have you asked your colleagues first? Have you asked for your colleagues first before asking her to help you?
Jennifer, you said you read it up. Go and read it up. Go and read it up and paste it. Go and read it up. Help her now. Who's in ENT posting?
IJ is there. She's not around. They have IJ is there, but I think they had a late clinic. And they have an early surgery tomorrow.
Okay, let me try the grading.
IJ is around now.
IJ is here.
Okay.
Let Jennifer go and read it and grade it.
IJ says she wants to help.
IJ don't help her. Short scores. Jennifer, go and read it.
It's an opportunity for IJ to present and she's an exam candidate.
Now, if IJ is ready,
so vibrate. IJ, tell us.
Okay, there are 4 grades. First of all, there is grade 0. There's grade 0 when the tonsils are located within the tonsillar fossa. Then grade 1 is when the tonsils occupy less than 25% of the oropharyngeal diameter or width. Then grade 2, when the tonsils occupy 26% to less than 50%, or to 50%, yes, of the oropharyngeal diameter or width. Then grade 3 is when the tonsils occupy 51 to 75% of the oropharyngeal diameter. Then grade 4 is when they occupy greater than 75% of the oropharyngeal diameter.
Hey, this girl, you're doing all your postings well.
Yeah,
what is that? What is that last stage called?
When she was in anesthesia, she was delivering. She's in ENT.
And what is that last stage of the? What is the last stage called? The last grade.
The one of over 75%.
Hey, Chief, I don't know what it's called. What is it called?
Were you not listening to the question?
Is it the kissing tonsils?
Kissing tonsils.
Yeah.
Tonsils.
And then, sorry, a point of correction, Dr. IJ. All of them are located in the fossa, so that is not a good way to introduce the first. You understand? All of them are located in the fossa.
0
is the first one is in the fossa. So the first one may not be visible.
Yes.
All of them are in the fossa. So you may not, when it's not visible, and the patient has not had surgery and all that, so you can say that is grade 0. Or even if the patient has had surgery and there will still be some tissue may still be, some tonsillar tissue may still be left there. So
yes, grade 0 is also post-tonsillectomy. Post-tonsillectomy is also grade 0.
Yes.
Okay.
And we're supposed to use this grade. We're supposed to use this grading when we are examining the tonsil.
The tonsils, yes.
Clinic. You're supposed to say, because you're supposed, when somebody is reviewing your examination finding, they should be able to have a picture in their mind how large are those tonsils when you were seen in the clinic. So you say it's a grade 1, it's a grade 2, it's a grade 3 sized tonsil. Thank you, Dr. IJ.
All right.
IJ, thank you.
Thank you, Dr. IJ. Thank you, Chief Akins. All right. So, Dr. Akins asked, what are the reasons for association of adenotonsillar hypertrophy with poor school performance? Do you know the relationship with adenotonsillar hypertrophy with poor school performance?
Kopkuk, you must answer this one.
Okay, yes, ma.
Yeah.
You mentioned some symptoms in your
It's in your
features.
presentation.
Yes, it's inside your clinical features.
Yes. Okay. Because of I know. Failure to thrive because of the enlarged tonsils. So the child cannot feed well. So if there's failure to thrive, then it affects the child's growth entirely, and also the whole performance in school, and also the symptoms that comes with it, the whole sleep disturbances, the
She's reasoning it out.
Yeah, you're trying to reason it out. You're kind of right. Some of the things you said, they're in line, and there are other things. You mentioned restlessness and all that.
Yes.
So concentration is poor, when someone is having some
Activity, excessive daytime sleepiness.
Exactly.
Sleep obstruction. Your whole day is finished. You don't concentrate.
Yeah.
Exactly.
Even halitosis, like you mentioned.
Yes, halitosis.
So they all contribute to, the learning ability of the child, and they affect his school performance, and ultimately affect his or her school performance. So they are all implicated. Most of them are implicated in that. So, Dr. Hickson was asking if you could recap the family medicine relevance to family medicine.
Okay. I said the family physician is usually the first point of contact in like 50% of the cases. So the treatment of especially the acute presentations, now we can treat them at outpatient basis. So that's why we need to familiarize ourselves with the like how to make diagnosis and how to pick up early signs, and then also knowing when to refer to is very important, so that as at an early stage the patient can benefit from either tonsillectomy or adenodectomy. Like I mentioned somewhere, the tonsils, once there's indication for removal, it doesn't interfere with the patient's normal life, because for most parts, there are other organs in the body that can give the there are other lymphoid organs in the body that can replace the functions of the tonsils and adenoids when they are replaced.
Okay. Okay, I think that's all for that. Okay, you mentioned prevention. How do you prevent? You mentioned something about prevention in the role of family physician. How do you prevent? You didn't mention details of how you actually prevent. How do you prevent tonsillitis and all this? How exactly?
Okay, I would like to know how to prevent.
Okay, like I said, especially for the acute infection, mostly they are viral related. So prevention will include like maybe early. How do you prevent?
How do you answer questions? How do you answer questions on prevention?
Okay, there's primary prevention, there's
Exactly.
secondary prevention, there's tertiary prevention, there's even primordial prevention. So for primary prevention, usually the risk is there. You prevent the patient from coming down with the disease.
The risk is there.
Yes. Yes, in primary.
Okay.
Then in secondary, the patient has come down with the disease. You want to prevent complication. Then in tertiary, you're managing complication. Yes, sir. So in primary, the risk is there. So you're preventing the patient from coming down with the disease.
So apply it to this condition. How do you apply it? Because you mentioned it in your presentation. How do you apply it?
I really don't.
Ask your colleagues. How do you prevent adenotonsilitis? especially in children? How do you prevent this disease from coming up?
Okay. Good nutrition, preventing like overcrowded places, because this is viral infection. It can be transmitted from one person to another. Early detection and treatment to avoid complication. I saw somewhere about even screening for Streptococcus pyogenes antibody. So, but I don't know if we do that in Nigeria anyways.
Have you heard about intake of yogurt?
Okay. No.
Okay, you know the commonest bacterial cause of tonsillitis is which
The
organism?
group A beta Streptococcus pyogenes.
Yes, okay. So in yogurt, some of the bacteria that is used in making yogurt include organisms. So that's the presence of those antigens from the yogurt, not lactamase.
Okay.
You're talking about enzyme now.
Oh, okay.
Okay, so those antigens induce some antibodies to strep organisms. So it has been, there is some level of evidence that people that take yogurt are less likely going to come down with upper airway strep infections, including tonsillitis.
Okay.
Okay. Thank you very much, Dr. Akins. Do you have any other contribution, comments?
Okay, well, I wanted to add with the importance of differentiating viral causes of acute tonsillitis from bacterial causes. You know, clinically, because as family physicians, you know, it's important to manage resources and not to send every case you see, send for throat swab MCS. And of course, if you come back, they tell you they are picking Staph aureus, you know. Yes, and you might be overloading the patient with a lot of antibiotics unnecessarily, you know. So when we are examining and you see there's widespread hyperemia, no exudates, the lymph nodes, there are no particularly tender and enlarged lymph nodes, most likely, and then there's also catarrh, associated catarrh, and all that. So wait, I'm in a meeting. I'm coming. I'll talk to you later. So sorry, please. So with those features, you can actually presumptively make a diagnosis of a viral cause and give the patient supportive treatment instead of starting antibiotics. And then you can give a short appointment to be able to review if there'll be any improvement. But if there are other features highly suggestive of a bacterial cause, then you start antibiotics immediately, because sometimes the culture might not even be representative sometimes. So that's what I wanted to add with the role of family physicians.
Okay. Okay, so can I ask a question? What about the one that is caused, the viral infection caused by Epstein-Barr virus that gives exudates to as clinical presentation? Do you still use the antibiotics or?
Yes, that is also very important. You know, it's also called the kissing disease. You know, usually caused by or transmitted by Epstein-Barr viruses among teenagers and some young adults who got it from kissing. That has been reported. So now the thing is the what's it called? The exudates in bacteria tonsillitis is a little bit different from the exudates in Epstein-Barr virus. In Epstein-Barr virus, you have more membranous exudates. So, but in bacteria, you can still see some follicular pattern. You see some creaks and you see some pus localized here and there. But in Epstein-Barr, the whole tonsils can be covered with like a membranous pattern of exudate, very thick, and then you also don't have the tender enlarged lymph nodes that you see in bacteria. Sometimes it may be difficult to differentiate. So, and when you are suspecting Epstein-Barr, it's better not to give penicillins, because penicillins, when you give amoxicillin, augmentin, they develop a reaction there's a reaction that occurs when you give penicillins in the presence of Epstein-Barr tonsillitis, Epstein-Barr induced tonsillitis. Thank you.
All right, thank you very much. Thank you very much. Interesting topic, interesting interaction and discussion. Okay, Dr. Ebuta mentioned something about yogurt being typically for gut issues and airway infections. That's new. Okay, we're just hearing that too. Anyway, Chief Ebut, do you have anything to add to that?
No, I was just, good evening, everybody. I was just curious. Maybe Akins will throw more light. You were talking about yogurt and its ability to protect against airway disease. So that was what I was wondering.
I'm aware of the gut. Yeah, I'm just hearing the one for the
so the bacteria in the yogurt is called typically Lactobacillus, Saccharomyces, and the rest.
Yeah.
But the Lactobacillus has the ability, to produce an acidic environment. It has the ability to also, it has a less pathogenic tendency. So if it multiplies and occupies the gut, it allows less of the pathogenic organisms to take over. So it's almost the same thing. So the issue of protection in acute tonsillitis, I have not heard of it before. In fact, the only place I've heard of yogurt or ice creams in adenotonsillitis is after surgery.
After surgery, yes.
You have to give them something cold. So
cold, yes.
I think it would be good to see a reference.
Yeah.
To see a reference, and then in the absence of that, we have to be very careful, because if you go and say that in the exam as one of your preventive, that your people should be taking yogurt, that it will prevent acute tonsillitis or adenotonsillitis. I think if we saw a reference, then
maybe we'll post. Dr. Akins, maybe you help us look for any good reference and post on the group, so we can all enlighten ourselves on that. Because I also am aware of the gut, yogurt helping with gut issues. In fact, with the Linex and all that, you can remember it all has this Lactobacillus, Saccharomyces, and all that. So I'm not aware of this one too. So, but if Dr. Akins, since he has seen it somewhere, if you could help us with reference, so we can all enlighten ourselves on that. So, thank you very much, everyone. Thank you, Chief Ebut. Any other contribution before I end the meeting? It's almost 9 o'clock. I think it's been a fruitful discussion and a very interesting topic. Thank you again, Dr. Kopkuk. Wonderful one.
Thank you, sir.
Yeah. So I think that's all. I'll be ending the meeting now. So let's all have a good night.